Hello, everyone, and welcome to today's keynote webinar titled Cannabinoid Hyperemesis Syndrome Investigating the Mystery. This webinar is a part of the 7th annual event in the Cannabis Sciences virtual event series. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots. Before we begin, I would like to remind everyone that this event is interactive. We encourage you first to participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the bottom left of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Help Desk button from the lobby within the event. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits image located on the right of your screen and follow the process to obtain your credits. All right, now let's get started. I'd like to present today's speaker, Ethan Russo, founder and CEO of Credo Science. For a complete biography on our speaker, please find it on the left of your screen. Ethan, thank you for joining us. You may now begin your presentation.
Thank you, Kaylee. Welcome, everyone, to Cannabinoid Hyperemesis Syndrome Investigating the Mystery. I'm Ethan Russo. So, my conflict of interest is my company, Credo Science, does have a patent application in the US and other areas of the world in relation to material that's in this talk. Most of the contents will be contained in this article that was published in 2021, but I've updated some more recent information, and hopefully some of this information is new to folks here. There is a link to the article, but you can most easily find this at ethanrusso.org at the library tab. And just any of the keywords, probably hyperemesis, which means severe vomiting. That would probably be your best word. So first, what is cannabinoid hyperemesis syndrome, or CHS? This is an enigmatic syndrome. The first symptoms were described in 1996, but not put in the literature in a case series in 2004 out of Australia. And it's very interesting to me that the description that the authors provided then is very much the same as we would provide today. So they described a cohort of patients who were chronic users of high THC cannabis who developed an unusual constellation of symptoms and signs. That consisted basically of severe cycles of nausea, vomiting, and abdominal pain that were accompanied by a very strange behavior of hot showers or bathing, often hours at a time. Abstinence then as now seemed to be the only definitive treatment, but intravenous haloperidol or cutaneous capsaicin, the active ingredient in chili peppers, may temporarily abort an attack. Interestingly, more standard antiemetics like ondansetron and granisetron do not work well at all. Some more facts about CHS. The largest case series prior to what we're going to present today was in 98 patients from the Mayo Clinic. There was a 2018 journal article, and all these references are in the paper to which you'll have access. They documented 105 prior studies that had been published encompassing hundreds of patients. The best theoretical article is by Marika Devono in 2020, and she described 3 phases of CHS: a prodrome or beginning, where people have some degree of nausea and vomiting, anxiety and sweating, and this is followed by the classic hyperemesis, repetitive vomiting with abdominal pain and the compulsive hot water bathing. And then, should someone stop the exposure, stop using cannabis, they will have recovery following the abstinence. In a study in 2012, which is already 12 years ago, it was estimated that people could spend up to $95,000 in emergency room visits or tests prior to getting a diagnosis of cannabinoid hyperemesis syndrome. Well, that was then, and there may be better recognition, but we also have a situation of people being labeled as this if they've ever used cannabis and come to the emergency room with vomiting. So mistakes can happen on either side. Unfortunately, there have been at least 2 deaths attributable to CHS, not from the disorder itself, but from secondary hyponatremia, low sodium in the blood from all the vomiting. As mentioned, standard antiemetics are poorly effective. This is from the Devono article in 2020, and you see a complex pathophysiology here. As one would imagine, when you have a syndrome with severe vomiting and abdominal pain, it is extremely stressful. And so there is definitely involvement of the hypothalamo pituitary axis involved with stress. Um, at the time this was written in 2020, the theories about how this came about. Number one would be a biphasic nausea and vomiting response to THC. Let me explain. THC at a low dose, everyone knows, is good to allay nausea and vomiting, such as in preventing difficulties with chemotherapy. However, at a very high dose, anyone can become sick with too much THC. Um, Additionally, if there's a constant exposure to THC, there will be a downregulation of the CB1 receptor where it works, and it can functionally act like an antagonist instead of a stimulatory agonist. Again, activation of the HPA, hypothalamo pituitary axis involved in stress. And she also talked about a possible genetic predisposition, which was as then at that time was undefined. And hypotheses included problems with the CB1 receptor where THC works, or the fatty acid aminohydrolase enzyme that breaks it down. Also, some people had implicated pesticides or neem exposure, but these have been unsubstantiated, and I'll have a little bit more to say about that. A strange study was done in New York in 2018. They surveyed patients at the Bellevue Emergency Department that were there for other reasons, not for nausea. And they queried about their cannabis usage and whether they ever got relief of vomiting or nausea with showers. So they basically created their own definition of CHS, which may not be accurate at all. But their estimate was that basically a third of heavy cannabis users might have CHS. If we extrapolate that to the US population, it would mean 2.75 million people had this problem. Other estimates have ranged as low as 350,000. I suspect that the true figure is somewhere in the middle. Now, a very important point of distinction is it's apparent that this is related to cannabis usage, but it doesn't have to be herbal cannabis. So in 2013, there was an extremely well-documented case of a 30-year-old male who had intractable pain, nausea, and vomiting on Dancitron, the serotonin type 3 receptor antagonist didn't work. He was better with hot showers. And this has gone on for 2 years, and he had countless diagnostic tests that were negative. Previously, he'd used cannabis for 17 years, but stopped 6 months before because he had urine drug testing at his work. So instead, he was using synthetic cannabinoids. These are compounds that are high potency agonists at the CB1 receptor, some of which were developed by John Huffman, the late scientist, never for this kind of purpose. So evidence of these compounds were found in the urine, but there were no metabolites of THC or other phytocannabinoids. So his symptoms cleared after 2 weeks while he was abstinent from using this synthetic cannabinoid. So this clearly shows that this is due to agonists, drugs that stimulate the CB1 receptor, and it doesn't have to be just herbal cannabis. Um, More recently, there was attribution of synthetic delta 8 THC to uh, causing CHS. So this is a 38-year-old woman that had a prior sleeve gastrectomy, presumably for obesity. She had 5 days of nausea and vomiting, had an abnormal scan. Um, she had positive urine drug screen for cannabinoids and opioids, and had been using uh, delta 8 THC gummies as a sleep aid for a month. They felt that she had CHS, and she responded to haloperidol and topical capsaicin, which does support that. The history is not as ironclad as we may like, but because delta 8 THC is a weak partial agonist at the CB1 receptor, like delta 9 is, it's certainly plausible that it would cause CHS in a susceptible individual. This one's more questionable. Last year, CHS was attributed in a 6-year-old who had Lennox-Gastaut syndrome with severe epilepsy after encephalitis. Um, the patient developed episodes of emesis over 6 months, lasting a day or two. Um, this child was on high dose cannabidiol as Epidiolex. Um, the authors implicated CHS due to CBD as the cause. After this was taken off, there was one more vomiting bout, but then none after 2 months. Just for way of explanation, Epidiolex is 98% pure CBD. The residual THC concentration is extremely low. I think this is questionable. Certainly, there may have been other causes, and we don't know whether absolutely pure cannabidiol can be implicated here. It's possible that it's not. In 2021, I published this short study to try and myth bust some unsubstantiated causes of CHS. Various things have been implicated. There was this fellow that thought that hop latent viroid, which is an infection of the cannabis plant, could do it, but no plant virus has ever extended to humans, let alone the hop latent viroid. Also, pesticides and neem oil had been implicated. I recently did a deep dive on neem oil, looking at the toxicological literature, and it's apparent that symptoms in the rare case of toxicity do not match here at all. Additionally, the main ingredient, azadirachtin, has an extremely high boiling point, 792 degrees Celsius, which would be about what you could get at the very tip of a burning joint, but it'd be highly unlikely that this would even recruit uh, in a way. So these just don't fit. Looking more at pesticides, it's apparent that these are a major public health issue. This is from an earlier study in 2016 looking at contamination of legal cannabis with numerous pesticides found, often in high concentrations. Now, these definitely have toxicities of their own, including neurotoxins, acetylcholinesterase inhibitors, but we know what acute problems with these toxicities look like. And again, these do not match those of CHS. So back to the study itself. Our project hypothesis was that perhaps this is genetic. Um, and the reason for thinking this is it's always been apparent that there are high volume users of cannabis that never have this nausea, vomiting, abdominal pain, and hot bathing behavior. Other people seem to get it. So, what's the difference? Well, again, we don't think it's toxins otherwise. So could it be genetic? And this would likely be due to what are called single nucleotide polymorphisms, or SNPs for short, or other mutations. And our working hypotheses were mutations in the genes encoding CB1, that's called CNR1, the cannabinoid receptor, or the TRPV1 receptor, where capsaicin and hot water work, or the enzymes that break down THC. So this would be undertaken by genomic testing, which we proceeded to do. So we developed an extensive screening questionnaire. Now this is a little different than some situations, and we should point out that this went through a institutional review board. We took a year to recruit with 585 total respondents. We had extremely strict criteria for entry, and it meant that someone had to carry a formal diagnosis of CHS plus have active symptoms. We did not want a situation where someone could have been misdiagnosed and really didn't have the condition. So they still had to have it. Of the 205 patients, 99 agreed to genomic testing and were sent kits to do the testing, but only 28 returned them. Unfortunately, we had a tremendous amount of pushback from the online CHS community. Some people questioned our motives, that we were just in it to make money, or they didn't like the questionnaire, or they didn't like that they weren't selected for the study. But we did get a lot of opposition. We also had 54 controls who were heavy cannabis users, but who lacked the symptoms, as we see. And as compared to the 98 patients in the study from Mayo Clinic, this was far and away the largest study that's yet been done in CHS. Now, this I'm not going to go into in detail. Suffice it to say that we use standard genotyping techniques that are well accepted in the industry to do the testing, which was done with a swab in the mouth, no need for blood. So again, we had this extensive survey, and of the CHS patients, which number 205, almost all were high frequency users, over 90% daily or multiple times a day, generally using cannabis flower or concentrates, and median intake was 4 grams a day of THC predominant material. So that is a very heavy THC exposure. 15.6% had carried diagnoses of cannabis dependency or addiction at some time, and over half had had withdrawal symptoms when they stopped. Almost all, 87.7%, improved when they quit using cannabis, but almost universally had recurrence after presumption. Among the 54 controls, they also averaged 4 grams a day. All of them were still pretty active users of cannabis, and 70% were daily or greater, mostly by, again, smoking high potency THC material. In contrast to the CHS cohort, only 3.7% had ever been told that they were addicted or dependent on cannabis, and 76% had never had withdrawal symptoms. Only 11% had ever been told that they should stop due to health reasons. Looking at some of the details in the survey, first, use rates, again, 97.1% of the CHS patients smoked. This is the cohort of 205. And if you look carefully, 4 grams a day was the median intake. Right. As far as the composition of the cannabis, the vast majority, 89%, used THC predominant cannabis, and that was true of the controls, where 80% were THC predominant as compared to having CBD or other cannabinoids prominent in the material. Why did people use cannabis? Well, In the CHS patients, 56% were recreational or adult use, 6% characterized it as medical, and 38% both. For purely medical patients, doses used tend to be lower, and we can't say that medical-only users never get CHS. We have seen this occasionally. It is much more rare. 44% of the controls cannabis intake was adult use in comparison. In terms of conditions, among the CHS patients, it's what you would normally expect. Chronic pain, sleep disturbance, migraine headaches, nausea, interestingly, irritable bowel, and a whole bunch of others. And it was largely the same for the controls medical usage where that was the case. Again, dependency or addiction. Um, uh, 79%, 22% said they had been diagnosed, only 3.7% of controls. Again, stopping use for health reasons, 92% of the CHS patients out of 188, and only 11% for the controls, despite having equivalent intake patterns. Withdrawal symptoms, again, 3/4 of the CHS patients, whereas 76% of the controls had never had withdrawal. When there was withdrawal symptoms, one would expect these: anxiety, panic, depression, insomnia, nightmares or vivid dreams, and irritability. So these are what are typically reported in anybody that reports withdrawal symptoms. Now, here is where we really have a divergence that's striking. Um, Periodic nausea and vomiting for the patients, um, uh, 16% had more often than weekly, 14% weekly, 40% once a month, and 30% once a year. This figure was zero for the controls. It's one way we made sure they didn't have CHS was couldn't have nausea and vomiting. Um, Hospitalization for nausea, 87% of the CHS cohort. Severe abdominal pain, 100% of the CHS patients had that, and zero for controls. Again, that was part of the deal. How often does it occur? As you see, 27% more often than weekly, 16% weekly, 36% once a month, and 22% once a year. Um, Hospitalizations for abdominal pain, 79% of the patients reported that. And if nausea, vomiting, or abdominal pain improved after cessation, uh, and 90% said yes. So again, this is the pattern that we'd expect. Um, was the condition improved by taking hot baths or showers? 100%. So again, this is something that is part of the described syndrome, and again, 0% of controls reported that. Have you been diagnosed as having CHS? 100%. Again, this is a requirement for entry. Um, as far as the people who got tested. So that's just sort of an internal control. How long did you have symptoms before diagnosis? And this is really striking. 61% a year or more. That's a lot of suffering. For 21%, several months, and only 7% were diagnosed right away. What treatments had you tried in the past? Standard antiemetic drugs, opioids, I don't know how that would help. Cannabis itself, capsaicin applied to the abdomen, hot bathing, etc. How long did episodes last? 69% several days. For 15%, they were ongoing, so persistent symptoms. Did the condition improve after cessation? 90% said yes among the CHS patients. Um, Now, this is a key one. After a period of abstinence from cannabis, did you resume its usage? 79% said yes. And this is something we've seen repeatedly. Even in the face of severe illness on a repetitive basis, CHS patients are very hesitant to control and often disbelieve that cannabis is really responsible. How long was it before symptoms returned? For 69%, more than a week. And for some, it was a lot less than that. Basically, what we have noticed is anytime someone escalates their THC dosage, they're subject to recurrence. Before symptoms returned, had you increased your cannabis intake? Again, 76% said yes, and this is a pattern that we've heard from patients. What do you think causes CHS? 38% said they didn't know and wanted to find out. 2% didn't believe in. Some thought it was pesticides or neem. A total of 8% there, and we really can rule that out. Some more educated people thought it was a problem with the endocannabinoid system or the TRP receptors. And some thought it was psychological, psychosomatic, which is unfortunate. Now, this is a comparison of the demographics of the CHS patients compared to the high volume cannabis users that were controls. Some differences in ages. In each, more women than men, probably because they have more patients to complete the questionnaires. Smoking, both very high. The differences, again, um, uh, we required that the controls not have any of these problems to avoid confusion. This is a summary of what we saw in the genomic testing, and we'll be going into much greater detail on these. For those not familiar, a p-value, any number less than 0.05 is considered statistically significant. And for 5 genes, you see that these are all below the 0.05 level. The higher number the odds ratio, confidence interval, means that there's a big difference between the CHS patients displaying the variant and the controls displaying the variant. So these numbers, the bigger the gap, the greater the confidence level. The first gene of interest was CNR1. That is the gene that encodes for the CB1 receptor where THC works, as well as the endocannabinoids. A SNP, a single nucleotide polymorphism, had previously been described with cannabis usage, but we didn't see this. And so our first hypothesis of a problem with the CB1 receptor didn't turn out to be the case in the CHS patients. But this was an important point of distinction because there is another condition called cyclic vomiting syndrome in which there have been abnormalities in the CNR1 gene. A close history will tell the difference. Cyclic vomiting syndrome usually begins in childhood where there's an unexplained episode of vomiting. There's usually a strong family history of migraine, and these children go on to have more classic migraine symptoms when they're older. Interestingly, cannabis usage helps this, and there's no evidence that makes it worse, but you see how it could create confusion, but genetics may tell the difference. Something we had not necessarily counted on was a mutation in the COMT gene, catechol O-methyltransferase. So this is what breaks down catecholamines like dopamine and norepinephrine in the brain. There was a mutation with this name, RS4646316, in the intron, the entry area to this gene, in 57% of the CHS patients and only 10% of the controls. So when COMT is not working properly, it leads to an excess of the dopamine neurotransmitter. When this happens, it's associated with things like compulsive behaviors, substance abuse, gambling, and even sex addiction. This mutation also has been related to depression, rumination behavior, where you think of the same thing over and over, and heavy alcohol intake at a young age. Other variants are associated with other psychiatric problems: impulsivity, attention deficit, obsessive compulsive disorder, anxiety, and psychosis. Also, cognitive impairment, difficulty thinking after cannabis usage was previously described in relation to this gene. One of the hypotheses that we made was a problem with the TRPV1 receptor, and that did turn out to be the case here. Mutation with this name was seen downstream in the gene in 71.5% of CHS patients and only 30% of controls. TRPV1 has been linked to anxiety and pain responses in the brain. It mediates long-term depression in the hippocampus, and controls glutamate release in the solitary tract nucleus, which affects gut movement and secretion. Um, eh, Interestingly, in a prior study of cannabis-dependent patients, they didn't see TRPV1 polymorphism, so presumably they were not CHS patients as well. This was a different mutation than had previously been listed in the National Library of Medicine database, but it suggests a linkage of CHS to mood and gut disturbances and helps explain the hot water bathing behavior and the efficacy of capsaicin, which is a stimulant and desensitizer at this receptor. Another of our hypotheses that was borne out was a problem with the metabolic breakdown enzymes for THC. And specifically, the most common is cytochrome P2C9, CYP2C9. Here, there were two copies, a homozygous mutation in the intron in almost half of the CHS patients and only 10% of the controls. Again, CYP2C9 is the breakdown enzyme for various drugs, including THC, 11-hydroxy-THC, its active metabolite, and also some endocannabinoids. When this enzyme is hypofunctioning, it could lead to accumulation of THC and again kick in that biphasic dose response where people vomit because of THC. Also, it could mean that there are abnormal metabolites that could be toxic that were formed. There'd been a prior case of mutation on this gene along with CYP2C19. That patient had CHS with cannabis dependency and a personality disorder. All of a sudden, a second gene affecting dopamine came up. So the DRD2 codes for the D2 dopamine receptor, which is the target for most antipsychotic drugs. Here we saw a mutation in the intron in 61% of CHS patients and only 20% of controls. When drugs stimulate the DRD2 receptor, they provoke vomiting and also affect movement in the gut. This mutation has previously been associated with depression and anxiety. Other mutations on the same gene are associated with addiction to tobacco, to Tourette syndrome, and chronic pain. The fact that we had a problem with the DRD2 receptor as well as with COMT that breaks down dopamine, again, helps explain the nausea and vomiting and psychiatric associated symptoms of CHS. The final fifth gene where we had positive findings was called ABCA1, the ATP binding cassette transporter. Again, two copies, homozygous mutation in 67.9% of the CHS patients as compared to only 20% of controls. This gene affects cholesterol and other phospholipid matters. and it's been associated with accumulation of abnormal material, ApoE, and A beta deposition in Alzheimer's disease. Um, Unfortunately, and we don't know, but this is a warning sign here. 2 copies of this in the CHS patients could imply that they're at greater risk for dementia later in life. But additionally, other risk factors for coronary artery disease and type 2 diabetes. Polymorphisms in a related gene, ABCB1, were associated with cannabis dependency. So, conclusions. We found 5 mutations with very plausible etiological roles in the phenomenology of cannabinoid hyperemesis syndrome that were statistically significant as compared to high volume cannabis users that did not have these problems. We believe that this battery may represent a screening diagnostic for susceptibility to CHS and could be something that's done earlier in the course rather than engaging in invasive tests, scans, barium enemas, and at repetitive hospitalizations. And this was taken from the paper itself. I'll just read. Cannabinoid hyperemesis syndrome can contemporaneously be conceived of not as a functional or psychosomatic gastrointestinal disorder, but rather as a manifestation of a gene-environment interaction in a rare genetic disease, unmasked by a toxic reaction to excessive THC exposure. We have a web page that is meant to be a resource for CHS patients or their families or interested individuals. The simple way to find that would be at what-is-chs.com. What-is-chs.com. There's also a link there to the test that can be done for screening purposes in this disorder. So that's the end of my presentation, and hopefully we've left plenty of time for questions.
Thank you, Ethan, for your informative presentation. Yes, we've got plenty of time for questions here, so we will now start the live Q&A portion of the webinar. So to our audience, if you have a question that you'd like to ask, please do so now. Just submit a question in the Ask a Question box located at the bottom of your screen. All right, so let's get started. My first question for you here is what is your opinion as to why capsaicin is effective in reducing CHS?
Okay, so very good question. Capsaicin is a fairly high potency agonist of the TRPV1 receptor. So this receptor is stimulated by heat, and by capsaicin, by ethanol, and by low pH, so acid environment. Interestingly, although capsaicin is not well absorbed from the gut, if you have too much chili, you may feel it subsequently because it will go through the gut unchanged. But it is absorbed through the skin and presumably then gets into the bloodstream and could go to the gut, go to the brain. And we know that there are TRPV1 receptors both in the gut and in the brain. And as mentioned, these work on tractus solitarius that will get the gut moving instead of being sort of frozen, and also modulates nausea reactions. So technically, there's a very plausible reason that it works.
Great, thank you. Our next question here asks, what has cannabinoid hyperemesis syndrome been linked to?
Um, this is delicate, but I really need to report what is true. We're seeing in these patients a high degree of addiction potential, and it's not just problems with cannabis. A lot of the patients have had previous difficulty with alcohol, tobacco, opioids, you name it. Additionally, we've seen a tremendous amount of anxiety, as you can imagine, with a painful, serious condition. And as mentioned, there'd be the susceptibility to other difficulties, including psychosis and later in life, um, possibility of Alzheimer's disease, coronary disease, and diabetes. So we consider this a very important public health issue. And certainly, we would hope that patients that have manifest CHS would think about these other issues and try to reduce their risk factors on the cardiac side and weight gain and consider treatment for possible addiction issues.
Great, thank you. Now, when was cannabinoid hyperemesis syndrome first described and or introduced?
Right. So 2004 in Australia, it was a cohort of 8 patients, but one of these poor individuals had had it since 1996. Um, Now, people wonder, did this exist before? Yeah, sure, likely. But a couple of factors. One is maybe no one put two and two together. Additionally, it is true to say that higher potency cannabis products are more available these days than they were in the past, although they have been available less widespread fashion in the past. Again, there may be more of this now because there is a better recognition. But again, that can work both ways. We have numerous examples of a young person who may have smoked cannabis in the past who is vomiting for some other reason that gets unfairly pegged with a label that is not accurate. But that's modern American medicine. Chances are the emergency department physician isn't spending a lot of time with each patient. And so this is a real potential pitfall.
Thank you, Ethan. Looks like we have time for one more question here, so we'll wrap up after this one. What symptoms does CHS consist of?
Uh, as we've listed, it is nausea, vomiting, abdominal pain, and the hot water bathing. So it's a quartet of symptoms and signs. That is really it. And again, we can say that the cause is either high THC cannabis usage or use of other CB1 agonists like the synthetic cannabinoids. And that's it in a nutshell.
Great. Well, thank you so much, Ethan. This will conclude our session for today. So I want to thank you for your time and your important research. And before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 1 year until April 17th, 2025. Labyrinths will alert you via email when it's available for replay. So we encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.